Welcome everyone to the Novo Nordisk Network virtual seminar series. We're really excited to come to you today with our speakers that I'll tell you about in a moment. But first, I'd like to start with a land acknowledgement. We would like to acknowledge the land on which the region of Peel operates, which is part of the treaty lands and territories of the Mississaugas of the Credit. And for thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe-Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. I would also like to acknowledge the land on that I am currently residing, which is part of Treaty 13. We are all grateful to have the opportunity to work on this land, and by doing so, give respect to its first inhabitants. Welcome, everyone, and thank you for attending today's Network for Healthy Populations seminar, Report, Reflect, Resolve, Shaping Inclusive Spaces for Patient and Caregiver Voices in Healthcare Decision-Making, presented by Dr. Ambreen, Sayani, and Elise Maybee. Before I introduce you to our speakers today, I'd like to quickly review some housekeeping notes. First, we appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of today's session, and we will also be inviting questions both through the chat box as well as using the raise hand function. If you have questions during the event that you would like the speakers to address, please enter them in the chat box and we'll do our best to respond to them at the end of today's session. Lastly, please note that today's session is being recorded and we will make the recording available on our network website. Now, it's my great pleasure to introduce you to our speakers for today. Dr. Ambreen Sayani is a physician, social scientist, and policy advisor. She leads the Improving Cancer Care Equity, or ICCE lab at Women's College Research Institute that aims to improve cancer outcomes for all population groups by promoting equitable cancer prevention, early detection, and access to high-quality care. Dr. Sayani is an assistant professor at the University of Toronto's Dalla Lana School of Public Health. She's a health quality expert advisor for the Canadian Partnership Against Cancer and the co-initiator of Equity Mobilizing Partnerships in Community. She has received multiple awards for her leadership, research, and innovation in patient engagement, healthy policy, and cancer care equity. Elise Maybee has been a patient partner in healthcare since 2011. She collaborates in many aspects of healthcare, including on research projects and areas of service delivery and policy. Elise has worked in technology, training women on assistance to use computers and get jobs, and later designing large software systems, including one for doctors' clinics. She advocates for health system change and patient and public engagement. Elise looks for new ways to involve people from all backgrounds and communities, which led to co-initiating Impact, a community table for people with diverse lived experiences focused on health equity. Elise is a co-founder and co-chair of the Patient Advisors Network, a national community of patient and caregiver partners. So thank you, both of you, for agreeing to present today. And without further ado, I will pass it on to Dr. Sayani and Elise Maybee.
Thank you so much for hosting us here today. It's nice to see a cozy small group. So I know Elise and I have a bunch of slides to present your way, but I think we'll just use that as a setup for a conversation. So we look forward to a really good discussion at the end. So I'm going to share my screen and hopefully tech will be on my side today and we can go straight forward. Okay, almost there. And I think we're good. All right. So today's session is essentially about power. And I want to set the objective with this quote from Michel Foucault, which drives a lot of my own thinking in this space before I met Elise, and it just continues and resonates throughout our entire program of work that we do together. Power is pervasive, and its pervasiveness is directly proportionate to the degree with which it is invisible. And really, the goal of our session today is to talk about ways in which we can make visible the invisible mechanisms through which it operates. And if we've done that, we've done our job. So if you can think through one or two ways in which you can recognize power by the end of this talk, that's a good step forward. So we will talk to you about different definitions such as power to, power over, and power with. We'll talk about concepts such as place and space, and then we will share with you a co-created tool called the Power Wheel. This is the outline of our talk. We've had a very generous introduction to ourselves. Thank you so much for that, Lorraine. But then we'll also talk to you about how we thought structurally, and we'll invite you to join us on that journey. We will share impact as a model of power sharing, and then get into the weeds of the power wheel. So let's situate the self. And this is super important because when it comes to power, one of the ways in which to contest with it yourself is to understand your own degree of privilege and access to resources and truths that you hold close to your chest. So in order to understand those, I want to share with you my worldview. My worldview is shaped by the idea that knowledge isn't neutral. It has been created and shaped by social and historical forces. There are many facets to the truth which are shaped by oppression, and that mainstream research kind of reproduces the status quo. So we need to interject ourselves and understand what's happening. And this can very often happen through places where we have dialogue, which is what will happen later today. But I'm also action-oriented. So what that means is I use my position as a scientist in order to advocate and do research that improves the goals of justice and inclusion. It was along that journey that I started to ask questions about my own research program. Who am I engaging with in my research program? Which patient partners tend to be excluded? If I'm designing a program based on equity and inclusion, why is it that the mainstream only tends to include a certain demographic of patient partners? And it was along that journey that I met Elise, and we started to think together about some of the issues that could be at play when it comes to patient partner inclusion. Elise, I'll pass it to you.
Yeah, so as humans, we're a complex of many identities and social economic influences. For instance, we may be Black, trans, and wealthy, or we could be a well-educated newcomer who does not speak English well or have a place to live. It's this tapestry of intersectional identities that brings the richness to our work. So next slide, please. So let me introduce myself. I'm Elise Maybee, and you heard my bio, so I won't go through that, but I've been a long-time patient caregiver partner, and I've thought a lot about many things. And while I have two focuses, one of them, which is what we'll talk about today, is in innovations in patient engagement. How do we make it possible for the complexity of our society to be reflected in the engagement we do with patients and caregivers? So next slide, please. And as you can see, I'm the usual suspect, as they call us, white, female, and older. And I think most of us, the majority of us, reflect this demographic. So I'm also frequently asked, how do we engage with folks who are not like you? Cracking this nut is central to moving patient partnership to the next stage. And as a person of privilege, I became interested in how to involve those that we don't usually hear from, and what role I can play as a person of privilege. Then I met Ambreen, and we found that we shared a deep interest in advancing health equity and in looking at different ways to engage folks not usually found at the healthcare tables. That brought us to co-initiating Impact, as you heard, and I'm constantly thinking about the role that I play in bridging between those with some privilege, like myself, and those with less. Next slide.
Thanks, Elise. So As a critical social scientist, I often have a toolbox of social theories in my back pocket. But I do want to take everyone through a couple of terms that have guided the ways in which we've approached thinking about structural exclusion, because it isn't happenstance, it is created. And those mechanisms, although they are invisible and can often be unintentional, they do actually have very harmful consequences. So social location, also commonly referred to as the social position, it's a rank order that people occupy on a ladder of power, privilege, and prestige, and where they interlock kind of places all of us on a certain position within society. Many different aspects intersect to create this position. It can be our gender, our age, religious affiliation. It can be the amount of income we have access to, or whether we have any abilities or disabilities that influence our day-to-day functioning. By virtue of the distribution of this power, privilege, and prestige across society, people tend to cluster into groups. And these groups then represent a certain degree of social inequity, just because this grouping has been shaped by the unequal distribution of power and privilege. What's super important is when people that hold degrees of power and privilege become responsible for the decisions and the everyday practices, which then permeate and influence the lives of everybody else. What happens is an institutionalization or entrenchment of a certain way of being. Paulo Freire describes this as the ability to exclude certain people based on who they are, making them helpless agents that become the passive recipients of oppression. When we think about this, all of these social contexts, and place them in our setting of institutional patient engagement, this is the point in which Elise and I met. We're thinking about exclusion, we're thinking about structural exclusion, we're thinking about everyday practices that continue to exclude people, creating further marginalization between groups. And then we think of the status quo of patient engagement, which very often happens in this setting, which is institutionalized. It is institutionalized because researchers like myself, we apply for grant funds, which are held within institutions. We are given this grant money typically based on a very rigid and tight timeline. We have milestones to hit. We have deliverables to deliver. There are certain policies that guide the ways in which we can meet people, how we can honor the ways in which people contribute their time, including compensation. So some of these create very structured hurdles or policies that continue to create barriers to including more and more people. Elise, I'll pass it to you.
Yeah, so this is a good look at the institutional model of patient engagement, which brings patient and caregiver partners to the healthcare table. We're invited into the healthcare environment on terms that are usually determined by the organization. So, for example, engagements are usually time limited in some way. In most cases, participation is voluntary, although that's changing. Meetings are being held on days and hours and locations agreeable to the healthcare professionals, and the focus is on the healthcare professional agenda. Also, our relationships with staff are often fragmented due to the episodic nature of projects. Next slide. But the world outside us is quite different, whether we're in Toronto or Peel. What we see outdoors is very different from what we see around the patient engagement table. Almost half of us are not born in Canada. Almost half don't speak English or French as a first language, and 1 in 5 have disabilities. Next slide. Who decides what parts of us to be listened to? Which of our multiple identities? Which of our multiple experiences? And who is inadvertently omitted by these decisions? Labeling people by their identities can be harmful and restrictive. People in healthcare often view us as objects to be acted on, patients, if you will, not me, the person. And this is othering. It removes our control over our bodies, our decisions, and our health. Next
Thanks,
slide.
Elise. And to the same point, so power and privilege become self-reinforcing. People with certain degrees of privilege end up at those decision-making tables, reinforcing the power mechanisms that exclude others, turning them into objects in their own lives. So let's talk about power in a little bit more detail. As we've mentioned earlier, it's mediated through a variety of ways. So our norms, our cultures, our practices, the everyday ways of being, these are all invisible mechanisms through which power remains pervasive. But if we think a little bit about it, who is involved in decision making? How do they get to decide? How do they get to the tables where decision is being made? And what is the relationship between the people at the table that allow people to express their concerns or not? How are resources distributed in society? Who has the ability to decide who gets access to resources and who doesn't? How are hierarchies maintained? But ultimately, who is accountable for this power distribution? And what we will argue today is that when it comes to places and spaces of patient engagement, it is the responsibility of the fund holder to be accountable for the distribution of power within their projects. We can understand power as the ability to act. I've got 3 definitions up on this slide, and they've been used to inform our work. Power over is the asymmetric relationship between 2 groups of people, such that one exerts power over the other. Power to is the ability to produce an outcome of my interest. And power with, it's the collective mobilization of a group of people towards a common outcome. We're going to take you to explore with you impact and how it's a model of sharing power with the public.
So, yes, so how did we think about this? When we were co-designing an approach to inclusive patient engagement, we started fresh. Institutional patient engagement was struggling with ways to authentically and effectively engage patient partners over a large section of diversity. So perhaps starting with a clean slate would free us up to find different and perhaps better ways to do this. Next slide. So this is us. This is impact. We don't label people or use prescribed categories to bucket them because we believe that labeling individuals is restrictive and harmful, which I said earlier. Our impact members are shown on our website, where each has taken time to share what they wanted to so that you can get to know them. What unites us all is the shared value of helping to create an inclusive health system, one that's socially just and fair for all. And we strongly believe for this to happen, we need to hear from people with diverse lived experiences with a view to applying a health equity lens on everything. Next slide. So what do we mean by diversity? A diverse community includes a wide range of expressions and experiences, including different gender identities, ethno-racial identities, sexual orientation, differences in abilities, and other identity factors. And what do we mean by community? Communities are by their very nature relationship-based. When we started with Impact by talking with people we already knew from various different backgrounds, We co-designed Impact organically, grounded in those relationships and those discussions. We are a community, and communities do not have terms of reference. Terms of limited time frame are transactional in nature, not relational. Communities usually have a common factor or purpose, and for us, it's health equity. Next slide, please. We partner with people and projects where there is a clear pathway to change. This does not waste our time, and it is not tokenistic, and it honors the time and experience and commitment we make. Next slide, please. As a non-traditional model of patient engagement, we flipped the paradigm. So decision makers request a seat at the Impact community table. Most models of patient engagement require patient partners to come to the healthcare or research table. The community model flips this paradigm. In this model, the community table exists independent of any projects, and the projects come to us. It also serves projects across multiple healthcare organizations at multiple levels, local, regional, and national. So it does not serve just one entity. Next slide, please. As Impact, we have a formal process that we co-developed for engaging with research teams and with others who come to us for an engagement. So there are three main elements to this. The first is creating a safe space. To do this, we meet with the decision maker and one or two key team members to coach them to achieve the best outcome from their engagement through a scoping and preparatory meeting, seen here in the blue. This is a key part of creating a safe space, and it's also where I use my power as a patient partner of privilege to help the team members set up the discussions in the best and most effective way possible. We also prepare the community beforehand with project materials and a brief discussion. The second element is the community consultation itself, seen here in green, where the decision maker and one or two of the key team members engage with members from the Impact community in a virtual meeting room to discuss the questions at hand. And then the final piece is closing the loop. And in order to do this, we create a written report with key findings and recommendations from the consult. And we ask the people who come to us to provide us with feedback on the changes that they make in their project or their work, which came as a result of the engagement. Or if they can't make changes, the why they can't make changes so that we can learn from it. Ambreen, do you want to add anything to this?
Yeah, thanks, Elise. So I think this looks like a really complicated slide, but what I would say is that this is what we've discovered is the secret sauce or the magic recipe that enables a safe engagement with community in a way that prioritizes and centers their lived experiences, but also creates a safe space for people from the healthcare system seeking input to be able to come and engage in dialogue with community without necessarily having the relationships themselves first. This is frequently a drawback of having project-based funding. Because the timelines are so short and so tight, we very often don't build in the capacity to have those long-term sustainable relationships with people in community. Having a place like Impact allows people within the health system to come and engage with a group that is structured to provide health equity analyses or assessments or recommendations to their projects in a safe way without having invested in the relationships themselves. What you can see is an intentional step-by-step process of sharing power between the health system and people in the public, but also creating accountability mechanisms so that there is a written report that comes out of this engagement. It includes recommendations that are tailored to the project. They're not all upstream. They're not all blue sky thinking. They're actually very focused to the project at hand, tied to making any change, moving the needle in whichever direction to make that project more inclusive. But then the idea that there's a feedback report means that there isn't tokenistic involvement. The moment people come into the engagement, they are committed to change. They're committed to working in dialogue with the community and providing feedback. And this has worked really well. We've been doing this since January 2021. This is not what Elise and I thought when we got together in June 2020 and just scratched our heads on inclusive and exclusive patient engagement. But the journey has been phenomenal in terms of the void and gap in the healthcare system. People legitimately want to take action for a more equitable health system, but they lack the tools, resources, funds, and relationships to be able to do it in a meaningful way. Impact has created that opportunity for so many people. We've worked from multiple hospitals within Ontario. We've worked for different universities, and we've worked for policymakers all the way up to the federal level. We create our own tools and resources, which we see as filling in the gap between what we're learning from the health system and what the public would like to see in terms of authentic, meaningful engagement. And this brings us to the Power Wheel tool, because this was one of those resources that the community felt really strongly about. So what you can see here is it was a massive team effort. There's more than 30 years of collective lived experience as patient partners within our group. And we didn't just want to problematize the issue of power. We wanted to solve for it. So drawing inspiration from Gaventa, who has described a power cube within the field of international development and the ways in which it relates to citizen and public engagement, we looked at that cube and can we draw inspiration from this when it comes to the practice of patient and caregiver involvement in research and in policy and in practice? And that's where we have come up with the Power Wheel. It is rooted in social theories. It is co-created with the community. And we invite you to click on the link, use the QR code. It is available as an interactive tool for you to go to the website, play around with, create your own Power Wheel, and join us in a conversation about what does it mean to make power visible? Also tell us, does the Power Wheel work for you? We're very curious to see what other people think of the tool. And we're actively going to, at some point in time, invite people who've used the tool to participate in feedback and interviews to tell us, how can it be improved? What are the ways in which we can use it to make a collective movement? So this is the Power Wheel. It contains 3 dimensions of place, space, and influence. Place being the level of decision-making, which is up for discussion. Space being the social relationship between groups of people, and influence the degree of power that people have in decision-making. So with that, I'll pass it to you, Elise, to take us through all of the levels.
Okay, so let's start with the dimensions of power, place being the one that we were to start with. It determines the level of decision-making that's open for discussion. Place can be at the micro or individual project level. So for example, I've participated on research into developing patient-reported outcome measures for the emergency department experiences together with Sam Viancourt. At the meso level, projects impact institutions or organizations or even communities. So for example, through the Patient Advisors Network, PAN, we co-designed the patient engagement framework for the Center for Digital Health Evaluation. And we continue to manage patient partners for the CDHE now for over 5 years. At the macro level, or a large-scale impact on, this has a large-scale impact on society as a whole. And as an example, I've had the privilege of being on the expert advisory group of the Pan-Canadian Health Data Strategy, which impacted federal legislation last year and the federal provincial transfer of funds for health. So now let's look at the dimension of space. Space determines the social relationship between people that share conversations around decision making. I can't give you an example of a closed space because as a patient caregiver partner, I'm not usually even aware of spaces where I am excluded from the decisions. Invited spaces, however, are more common in my experience. So, for example, the PFACs and councils and individual projects that I have been involved in are all spaces where I have been invited in, and this is the usual practice for patient engagement. Created spaces, where patient caregiver partners create their own spaces around a goal, are not that frequent, but they do exist. So, for example, Impact is a community table of patient caregiver partners from diverse backgrounds, and we've come together around a common goal of advancing health equity. So let's look at the final dimension here. Influence determines the influence we as patient caregiver partners have on decision making. At the inform level, this is actually an important level in cases where, for example, public health needs to inform the public about critical issues like COVID and where to get vaccines. For consult and collaborate, those two levels they share a sort of a continuum of the degree of influence that we have as patient caregiver partners. With the consult, we provide feedback which is considered, but there is no real obligation to let us know what is decided and the implications of that decision. So that often occurs through surveys or focus groups or different ways that we might also be engaged. Collaborate, on the other hand, is where decisions are taken more as a group, with patient caregiver partner input seen as equally valuable to the decision, and where we are usually told the outcomes of the decision. And most of the work that we do as patient caregiver partners falls in these two categories, consult and collaborate. The final category, decide, is a level where patient caregiver partners actually set the priority and decide what should go ahead. As an example, the SPORE Evidence Alliance program is where patient caregiver partners put forward their priorities for research. And if their topic is selected for funding, they pull together a team that implements the research.
Thanks, Elise. So when we put all the dimensions and levels together, we get this configuration of a Power Wheel tool. I have to give much credit to Dale Clark here because he spent almost a year in the design phase with us to get this to this shape and format so that it could become an interactive tool. We were playing with 3 different dimensions and a variety of different levels. And to create it in a visual format that was appealing, that could be interactive and could be used, took 12 months of co-creation. I say this because co-creation is time intensive, and it is as important to talk about the process as much as the outcome and outputs of the work. When you use the Power Wheel tool, it allows you to click on the different levels for each dimension. You can download it, you can share it as an image. I can give you examples of my own work and how I use it to report on power dynamics within my program. When I apply to funding agencies, if I've been engaged in a created space like Impact, I'm able to talk about the ways in which the group holds decision-making power through created mechanisms that are influencing a variety of different decisions. For other projects where they are grant funded and I need to invite people into the engagement space, it is a very different configuration of the Power Wheel. But what it also allows me to do is if that engagement and project continues over 2 years, perhaps what was an invited space that was initially created for consulting with the public it evolves into something different over time, provided the power sharing mechanisms are in place. That allows me to report on my project dynamics over time with transparency, with the people who I'm involved with, putting the accountability mechanisms on myself towards the project, the people who I'm engaged with, but also the funders who put their trust in my work. What I would encourage everyone to do is, no matter which stage of the power wheel you're at, start to report it, because this is the only way in which we can make visible the invisible mechanisms in which power is operating. And then perhaps a year from now, we can have another discussion at the same platform with the Novo Nordisk network, compare our power wheels, and then reflect as a group on, well, what is really going on here? Where is it working? Where is it not working? Where is power being shared? And what are those examples that we can learn from? Because we can maintain the status quo, but if we have a goal of inclusive spaces, if we're driven towards improving equity, then we must share power with communities that have been excluded. And therefore, it is not just a moral imperative, it is part of the work that we do. So let's reflect on the power wheels that we can create so that we can have a collective conversation around what needs to be resolved. I will share with you 2 examples of how the power wheel can be used. This is how we've used the interactive tool to create it for Impact. Impact, as we've mentioned, was co-created together with people with a variety of lived and living experiences with the goal of sharing power and improving health equity. Therefore, it is a created group, and the group gets to decide who from the health system they want to engage with. If there is a project that has tangible goals towards change, we welcome that interaction. However, if there aren't clear goals, if the engagement looks tokenistic, the group holds the power to deny that engagement. I will give you 2 policy examples that the Impact group has been involved in. And here you can see Impact is a created group. We collaborated on these projects, and they were both funding decisions related to high-level projects. We don't normally disclose who from the health system engages with the group, because we believe that's confidential information for health system partners to share if they like. I can talk about this because the health system partners are themselves very vocal about their engagement with Impact and have published the reports. So the first example I'll give is about the Canadian Drug Agency. They have engaged with Impact twice. Once was when they were still in inception, and they engaged with Impact to carve out and design their public engagement strategy. And they have recently, now that they are an official federal level organization, come back to Impact to understand how to action some of those parts of the strategy. This is very high level decision making with very macro level implications. The second example that I can give is of the recently created Novartis Health Equity Fund. And they came to us because they realized they didn't have the tools and conceptual understanding of health equity to be able to design and run that fund in a way that met the needs of people who needed that funding the most. We co-created that entire program with them. And during that process, we're able to carve out the mechanisms with which they reached out to public, the ways in which they socialized their program, even the evaluation criteria of who they eventually funded. Elise, I'll pass it to you for a final example.
Okay, so I'm going to talk about quality improvement example, which is pretty much a meat and potatoes of what many of us as patient caregiver partners do. So one example is that I was invited to be on a project to improve the workflow in the emergency department of my local hospital. This is a micro space that I was invited into. At the level of influence, I was consulted, if you will. I was able to provide feedback that was taken into account by the healthcare professionals on the project and that they used to make the decision. I was not, however, able to influence that decision beyond my persuasive ability to state the case for the patient experience in the workflow in the emergency department. So that is very common across many of the experiences for patient caregiver partners. Hey, back to you.
Thanks, Elise. So we've given you a deep dive into the power wheel. We've shared with you 3 different examples of how the power wheel can actually come into play. And we just want to close again with this quote from Michel Foucault, and the idea that knowledge isn't neutral. And knowledge and power both constitute each other. They're both different sides of the same coin. And therefore, we need to contest with the issue of power and create knowledge that is more meaningful across our society, that challenges the status quo and allows us to work from the margins in so that we all have a good chance of good well-being and health outcomes. What we've shared with you today is part of MPACT's Creating a Health Equity Movement. This is our working group charter. We're based in relationships of trust. We're grounded in listening and learning, not just from members of the public, but also from people in the health system, because it is this partnership that's going to make it work. And it is the sharing of power across this partnership that allows us to change the conversation. No change is a small change. Every change moves the needle. And when you can move the needle across multiple different projects, you're actually creating a movement in a certain direction. We invite you to check out our tools and resources. We're constantly updating what we provide on our website. And you can also contact us if you're interested in engaging with the group to improve the equity and inclusion perspective of your own projects. Most importantly, we'd like to acknowledge the tremendous amount of invisible support provided by Women's College Hospital to kind of pivot and move the policies and ways in which we engage with the public so that we can meet their needs and bring them in a way that honors the co-creation process. Also funding from CIHR, the Public Health Agency of Canada, because they see this as a movement and a model that can move the needle on health equity. Also, at this point, I'd like to thank Sandbox Consulting because they too spend a lot of time creating the interactive tools so that it could be used by everyone. And with that, we'll turn it over back to Lorraine to guide us through questions.
Ambreen and Elise, thank you so much for a very thought-provoking and well-presented talk today. We really appreciate your insights and your experience, and congratulations on all the great work you've done in such a short time. I'm going to open it up for questions. Please, if you have a question, please either put it in the chat or raise your hand. As people are thinking, maybe I can ask you a question. So your power wheel is a really nice framework for how to, think about the level of engagement and the level of influence that our, patient partners or community members have when we're thinking about these different types of initiatives that involve them and that have potential to impact them. But I also recognize, and I'm wondering what your thoughts are on the other power dynamic around time and capacity. So what I mean by that is, when researchers or healthcare providers or healthcare administrators or policymakers are coming forward with a problem they need to solve or with a project they need to initiate, that is their job. They have capacity, they have time, right? So that's what they're focused on. In contrast, you then have to bring in people who definitely have different perspectives and important roles in the type of work that you're seeking to engage in, but they may not have that as their central priority. They may be, patients, for example, may have jobs, may have families that they have to take care of. And so, and in fact, the ones who are most marginalized often have the least amount of capacity and time. So how do we actually resolve that balance between the amount of time and capacity to actually do meaningful work and to do the work that's required to have that equal decision-making power, with the fact that there is definitely an imbalance in how much capacity and time that people have. And the same goes for community members. And in fact, you know, when we look at nonprofits, for example, where you have, you know, the key role of volunteers working in these nonprofits, or working, you know, in these different types of settings, the volunteers tend to be people who have more time and capacity, right? Because they're able to volunteer their time and or even if we pay them, they still they have the time, right? So, yeah, so I just wondered what your thoughts were about that. How do you balance the capacity issue with yeah.
So, well, let me kick off that conversation because that was actually part of the discussions that Ambreen and I had. And it's, I mean, even for somebody like myself who has a degree of education and so on and so forth, and comfort in being at healthcare tables, you know, finding the opportunity to be involved and to have the capacity to understand what the issues are at the table is sometimes challenging. But what I would say is you can't decide, we can't expect the healthcare system to decide those things for us. These are decisions that we as patient partners should make, what we can and can't do. What the healthcare system can do, on the other hand, is to engage in conversation with us and say, here's the job at hand. These are the hours and timeframes that we have. How would you like to engage? Can you engage? What do you need in order to engage? Because each of the engagements that I've had over the many years have taken they've required a different capacity, a different understanding, different learnings that one has had to do. And the other thing is that there's no reason why all meetings need to be 9 to 5, Monday to Friday. There are many people in community who are motivated to make change, and they would be happy to contribute from 7 till 9 in the evening, for example, or on a Saturday morning, whatever that might be. So the flexibility needs to come from the healthcare side for those kinds of things. But also, the only way you're going to really know these things is to engage with people and see what it is that allows them to engage and what it is that prevents them from engaging. Ambreen, do you want to have something more to add?
I can just add that we had that image of starting with a clean slate. And I think that was one of the issues we were grappling with when we didn't set out to co-design Impact. It kind of just happened as we went along those conversations, and it got deeper and deeper, and we started to see this architecture kind of forming. We can sometimes assume the degree of involvement that people would like to have in projects and the resources and skill sets that people need. But I think it's a balance between the burden of being involved versus the desire for seeing change. And I think that's where we need to have those spaces where the burden of the engagement, it falls on the fund holder. I think eventually that's where accountability rests. It rests with the fund holder. And to make it as inclusive a process as possible without burdening people in terms of time and skills and resources. And that's tricky because people can have different needs and want to meet you at different places. I am going to put in the chat how we co-designed Impact because it details a little bit more about those questions that we were grappling with from the health system as well as from the public, and finding the sweet spot that brings people together.
Thank you. Thank you.
Can I just, I mean, I know we might want to go to some other questions, but I just want to add the other piece of it, particularly in research, is because research is so time bound by the grant cycle, the granting cycles. And what I've seen, particularly with early stage researchers, is that they have no real access to patient partners, never mind a diverse set. So, and then all of a sudden they get a grant and they have to go Billio to get it done and so on. And it doesn't allow them the time or support them in developing relationships. And that has to change from the grant, the funding agencies, that's the word I'm looking for. It has to go to the funding agencies to actually find ways of supporting relationship building, because it's all about the relationships, and having ways where researchers can test drive some of their ideas with members of community and learn from members of community that what really is important to them. Otherwise, research will be always disjointed, and that does nobody any good service.
Yeah, that's a very good point. Yeah, thank you. Any other questions from the audience?
I have a quick question. Thank you, Ambreen and Elise. Your presentation was very insightful. I'm definitely going to use the power wheel in the work that we're doing, because one of the challenges that we've had is identifying community members. I know sometimes we interchangeably use in our research community members or patient partners. And so for one of our projects, we try to garner interest from the community and learn about their unmet needs for accessing diabetes screening. And we had the funding ready to go, but it took a very long time and a lot of engagement with community partners and agencies and support groups, and until we recently learned about a specific initiative called the Better Women program, which you may have heard about. Their funding ran out, and they had a group of ambassadors in the community who were interested in providing support and identifying community members. Had we not discovered that group, we found that it was quite challenging to engage meaningfully, but also to retain these individuals in the research, in the publications stage and all of that. And so this is a bit of a loaded question, but more of a advice on what, in the beginning, if you face these challenges, what were some of the ways that you address that in the work that you've done and in developing the power wheel to overcome those barriers with recruiting and retaining patient partners?
Elise, do you want to go? Yeah, I can imagine.
Yeah, I'll start that one also. So to start off with, impact is an existing community. So you spoke about this group that you stumbled on that really helped you. So we already have that group in situ, and so we meet once a month, and we have the ability to meet on an ad hoc basis if we need to. And it's during those times that we work on things like the power wheel, and that we also come up with ideas about what are further tools that we want to develop to help this move this work forward. So we already have the community, which really goes to the question of developing those relationships, maintaining them over time, and that takes a ton of work. You're absolutely right. It's very time consuming. And the thing that we need to do is encourage the people who fund us to do our work to actually support the development of these relationships outside specific projects, so that when the projects do land, you have somewhere to go, you have a community and a set of relationships that you can piggyback on.
And I'll
Ambreen?
just add, it is a lot of invisible labor. There's so many resources, and I'm not just talking about money, I'm talking about human investment here, right? It's your personal, it's relationship based. Impact was also based on that model of we're not recruiting, we're going through networks of trust. So it's all of those trusted relationships that you're going shoulder to shoulder from, like, hey, do you want to chat with someone? Do you want to chat with someone? Do you want to chat with someone? And that's how we built out as a group. I do think for my own program, I use the power wheel chronologically. So what was it at outset? And if you start with a power wheel, which is very invited, meso, micro level kind of space, But then say after 12 months, it was actually just 3 people, but this was now more towards decision making and the power was more shared. I think that's actually pretty strong. Yes, you have 3 people, but you shifted power. Or you could stay in the same invited, closed kind of room with very little decision making power, and you're 20 people. So who's going to say which power wheel is better? I don't know. Let's talk about it a year out from now. But it certainly gives us a way to talk about our work using mechanisms and tools that didn't exist before. So your struggle could actually become a story you tell.
Thank you. The timing of your talk couldn't be more perfect. We're have our first advisory meeting this Wednesday. So very excited.
Thank you. Well, if there are no other questions, please join me in giving a big thank you to Ambreen and Elise for a really insightful and thought-provoking presentation. And thank you for sharing the resources and your tools that would be very useful for all of us. And we look forward to engaging further with you as we're continuing to do the work that we are doing. And thank you for those of you who attended today, who listened and participated. Please ensure that you complete today's evaluation for the session. Lydia's added the link in the chat pod, and this will also be sent by email directly after the session. So we will be taking a pause in our monthly seminars in April, but please join us for our joint Network for Healthy Populations BBDC Clinical and Population Research and Progress rounds. On the next date will be on May 12th, 2025, where we'll hear from some trainees. So please look out for this event flyer as we hope to open up the registration in April. And please do check our website frequently at healthypopulations.utoronto.ca for more information and to register for the event. We hope to see you all there. Once again, thank you to our speakers for a wonderful session today. All the best. Have a great day.